Sorry. Good questions. Perfect. Thank you.
Whoever has to watch the video.
So very interesting. What is it?
What are you talking about? Butler? That is
It's oh my gosh. When they are allergies. This woman surprises me. Anyways, she said it's time.
Can you guys see my screen?
Yep. Yes.
Cool. So hi everyone. My topic for today is sepsis. So I'll touch a little bit on the epidemiology, but focusing more on the pathophysiology and the management principles. So, I mean, all of us in ITU, we deal with septic patients almost on a daily basis. So I'm just hoping to sort of hopefully bring a couple of new learning points for all of us today. So annually and globally, there are about over 30 million cases of sepsis. About 2/3 are severe sepsis with end organ dysfunction, and about over 5 million deaths. These numbers are likely to be an underestimate because we don't really have much data from lower to middle income countries. And I think it's reasonable to assume that the incidence of sepsis is probably higher in those countries as well. So overall, it seems like the incidence of sepsis might be increasing. We don't really know for sure because it could be that we're just better at detecting sepsis and diagnosing it. Or it could also be due to the fact that different studies use different definitions of sepsis. So the numbers are a bit all over the place, and we'll get to the definition of sepsis in a bit. The percentage of septic people dying seems to be decreasing. So that's rather encouraging, means that we're better at treating it. But overall, because the incidence might be increasing, the overall mortality is increasing as well. So the 1991 criteria of sepsis, so it's based on 4 criteria. So you need to meet at least 2 of these to be classified as sepsis. So temperature, tachycardia, tachypnea, or PCO2, or a neutrophilia. So, I mean, this criteria is a bit problematic. As we can all appreciate, a lot of people with sort of mild to moderate localized infection can easily have 2 of this 4 criteria. And, you know, you might see them in ED, you might give them some oral antibiotics and send them home. So it's probably not appropriate to label these people as septic. So the proposed new criteria in 2015 sort of changed the definition somewhat. So, you know, there's some key terms here, so life-threatening organ dysfunction and due to a dysregulated host response. So this sort of markedly increased the threshold for someone to be labeled as septic. And also another important thing is that this organ dysfunction is remote from the site of infection. So it's like a generalized, systemic, exaggerated response, so to speak. And septic shock, on the other hand, is technically defined as requiring vasopressor therapy to maintain a MAP of more than 65. So anyone whose you know blood pressure is well controlled with fluid resuscitation alone isn't necessarily someone who is in septic shock, strictly according to this definition. So next on to the pathophysiology. So there are several elements that I'll be covering in the next few slides. So the first one will be just general regarding inflammation. So naturally, all starts with an infection. So the different cell populations around the body that are in charge with surveilling a local area, and also the blood system, like professional ones like antigen-presenting cells, they recognize certain antigens from that derive both from the pathogen itself or could be from endogenous dangerous signals as well. So mainly the PAMPs and DAMPs, if you guys know about those as well. So there are lots of different complicated pathways once these PAMPs and DAMPs are recognized, but ultimately they all lead to expression of several early activation genes. So these are responsible for producing the cytokines. So just because how complicated and how redundant and complementary these signaling pathways are, it gives the body opportunity to regulate the response via multiple entry points. So they can sort of skew the innate immunity response towards the class of pathogen that's in the body. Because, as you know, innate immunity is fast, but then it's not very specific. But then there is some specificity retained via this mechanism as well. So another important contributor to inflammation is complement, namely C5. So when C5 is activated to C5a, it acts as a potent chemoattractant. So it attracts mainly other white blood cells, and it triggers the release of enzymes from these neutrophils. And it acts like an amplifier of the inflammation of the cytokine production, and it is an important contributing factor to some of the main issues that we face in sepsis, such as systemic vasodilation, tissue damage, and multi-organ failure. So in several animal models, blocking C5a have shown to have improved survival and outcomes. And I believe some human trials have been started, namely for early intra-abdominal and pulmonary sepsis, but I'm not sure if the results are out yet. So next is a topic that perhaps might be less familiar to some of you, is the element of immune suppression in sepsis. So what we have come to learn is that even if a patient survives sepsis in its acute phase, they have quite a long, protracted clinical trajectory with waves of chronic inflammation and immunosuppression. So they've come up with a term for this. It's called PICS, so persistent inflammation, immunosuppression, and catabolism syndrome. So talking first about the chronic inflammation element, we don't really know what the etiology behind this. It's not like the acute phase where, okay, we recognize the PAMPs and DAMPs, we activate the genes, we produce some cytokines, we kick off the whole inflammation cycle. So we don't really know the etiology behind the chronic type of inflammation. There are some theories. It could be, due to opportunistic infections. It could be iatrogenic, surgical interventions, simply like placing a catheter in, or it could be due to like reactivation of latent viruses as well. So sometimes I think perhaps we can relate to this in a sense that in patients, they come into ITU, they're septic, we give them all the appropriate therapy, we start them on broad spectrum antibiotics, and they get a little bit better. And a few days down the road, suddenly they spike a temperature again, they get a positive blood culture again. So I believe that this is part of the process that underlies that kind of clinical picture. So next, touching on to the immune suppression side of things, there are many different mechanisms which underlie this immune suppression. So namely, we've observed that septic people in the chronic phase, they experience lymphopenia, they have immature myeloid cells, and they produce anti-inflammatory cytokines, and their antigen-presenting cells have lost their MHC class 2. So as some of you may know, the MHC class 2 is sort of an important structure that allows the APCs like dendritic cells and whatnot to present the antigens to the CD4 T cells. So that kicks off the immune response. So other than the reduction in these sort of loss of function in these mechanisms, there are other mechanisms which sort of basically do the opposite. So APCs, instead of activating T cells, they suppress T cells. Overall, this shifts the T cell phenotype towards a Th2 response. which is an immunosuppressive response. And these are underlying all this is an apoptosis of the T and B and the dendritic cells. So decreasing apoptosis in these cells have seemed to have improved survival in certain animal models, but I don't think there are any human trials yet. So the next element is the topic of endothelial barrier dysfunction. So in health, the barrier acts as an anticoagulant surface. So mainly it does this by protecting the underlying collagen fibers and tissue factor in the tissues and interstitium to the von Willebrand factor and factor 7 in the bloodstream. So in sepsis, the platelet and neutrophil adhesion and other inflammatory mediators like the cytokines and whatnot, they disrupt this barrier. And this leads to the leakage of vascular fluid and a migration of leukocytes. So the migration of leukocytes, it confers a survival advantage because that's where the infection, if that's where the infection is, you want the body to go and fight the infection. But because the elements of the components of the endothelium, like the glycocalyx, actin polymers, and tight junction linkers, they are basically everywhere. These leads to a generalized, excessive, and prolonged disruption to the endothelial barrier. So it happens everywhere, not just at the site of infection, and this causes considerable tissue injury and end organ dysfunction. So in relation to this, sepsis also induces a hypercoagulable state. So it does this via the activation of complement and also the von Willebrand factors and the extrinsic pathway of the coagulation cascade. So this leads to microthrombi formation in the microvasculature and leads to decreased perfusion and thrombus formation. So this sort of exacerbates the hyperperfusion that we see in sepsis as well. And working in conjunction with this, the endogenous anticoagulants like activated protein C and the fibrinolytic pathways are also downregulated. So this can lead to uncontrollable bleeding because all these the platelets and the clotting factors are being used up, and this principally underlies the transition to DIC. And inflammation and coagulation is sort of auto-amplified by co-stimulation, so it just causes a vicious cycle. Again, similar to the endothelial barrier dysfunction, this also has a survival advantage if it serves to wall off the infection site and limit the blood loss, but locally. But again, as you can see, the sort of repeated theme of sepsis, and also in the new definition, is that this is a dysregulated host response. So it's generalized, exaggerated, and prolonged. So widespread coagulation, it's or widespread coagulopathy. It causes DIC, which leads to septic shock. So next, I'll be touching on the effects on different organ systems of sepsis. So this would probably be more sort of translatable to clinical day-to-day. So on the neurological side of things, we can see lethargy, delirium, usually without any focal neurology. But of course, we would like to rule out other causes of lethargy and delirium as well. Next, on the chest side of things, you can see tachypnea, increased work of breathing, respiratory muscle fatigue, type 2 respiratory failure, ARDS. Cardiologically, we see a biventricular depression, leads to shock. So we usually classify sepsis as a sort of distributive shock, but there is also an element of cardiogenic shock in there as well. So the main difference between ischemic heart disease myocardial depression to sepsis-induced myocardial depression is that in IHD is usually predominantly left ventricle, whereas in sepsis it's more biventricle. And seemingly the role of nitrosative stress, so inducible nitrous oxide synthase, is quite important in this cardiovascular dysfunction. Next is on the effect on the renal system. I'm sure we're all very familiar with this. Sepsis and AKI almost always go in hand, and absence of full recovery of renal function is associated with poor outcomes. So, we see patients who have been septic for quite a prolonged period of time, and they remain anuric. And once you take them off the filter, they never reach what their kidney function was prior to the septic episode. And lastly, sepsis can also cause DIC. So DIC can present in one of two clinical pictures. So it can cause widespread bleeding due to consumptive thrombocytopenia, or it could lead to widespread thrombosis of the small and medium vessels. So what determines which picture it presents is down to the fine balance between between procoagulant pathways and anticoagulant pathways. So it's a very fine balance, and it depends on which way the body tips the scale towards. So next I'll be touching on some of the management principles. So obviously we want to promptly identify the source of infection, do the usual stuff, chest x-ray, urine dips, sputum cultures, wound swabs and whatnot. And then adequately control the source. So we usually, almost for everyone, you usually start with early broad spectrum antibiotics. And once the culture results have come back, we can de-escalate to narrow spectrum ones. And also important to keep in mind is if surgical interventions or IR interventions are possible. So, sometimes if you have a patient who, chest sepsis isn't really convincing and none of the cultures have come back, I think it's important to re-examine the patient top to toe, turn them around if you have to, even though it's going to be quite inconvenient. See if, they have a massive boiling abscess somewhere that you've missed, or a raging cellulitis that someone has missed. So we don't want to miss those things. And increasingly, there is a role for procalcitonin-guided antimicrobial therapy. So the evidence was sort of a bit conflicting for the last several years, but more recent evidence is more in favor of using procalcitonin to distinguish septic inflammation from other non-infectious causes of inflammation. So the other management principle is, of course, hemodynamic stabilization. And the management of this can be sort of broadly divided into 4 phases. So the salvage phase, optimization, stabilization, and de-escalation. So in initial salvage phase, it's it's probably more prudent to give generous fluid resuscitation unless there are contraindications otherwise. And in the optimization phase, you want to use a more individualized approach. If they're still fluid responsive, then of course you want to give more fluids. If they're not, then you don't, basically. And because overall in these 2 phases, it's likely that it's always that you're always in a positive fluid balance. And in de-escalation phase, once the patient's more stable, you want to offload that. And also, if needed, if they're in septic shock, for example, you want to start them on vasopressor or inotropic support. So the next slide is something that I thought might be useful, because oftentimes especially when we deal with really sick, really septic patients on ITU, the next of kins might be asking things like, oh, how will they do long term? How long will it take for them to recover? What are the what can we expect? So I think it's useful to keep some of these points that I'll be touching on soon in mind, just to manage the expectations of the patient and also importantly of the family. So sadly, there's little known about the quality of life and long-term mortality following sepsis. Most studies, they just follow up till like 28, 30 days, 3, 4, 5 months. But some of the data that we do have is not really encouraging. So there is considerable rehospitalization and considerable excess mortality rates post-severe sepsis. 60% have psychological disturbances. Most of them never recover to their functional and cognitive baseline. And, you know, a patient might be independent, living alone at home, and after the septic episode, it's very likely that they'll need a lot of support at home, or they might not even be able to go home. They might need to go to a care home, or needing a lot of MDT support. So age and length of stay in the ITU are independent variables of survival and recovery. I think above 55 years of age and more than 14 days in ITU are predictors of poor outcome. And we are increasingly recognizing post-ITU syndrome and PTSD for patients post-sepsis. So it's important that you sort of convey the message to the patient and the family is that, you know, they're going to need a lot of support, both physically in terms of physio, and also they're going to need a lot of support in terms of their mental health as well. So what does the future hold? I think there are many studies coming out in the last few years, and I'm sure there'll be many more to come in terms of modulating the septic response. So what I touched upon earlier is that there's the wave of inflammation, and then there's the immunosuppression as well. So we're trying to figure out ways to sort of tweak it to lead to more favorable outcomes. For example, if it's hyperinflammation, can we sort of tune down the inflammation, and does that lead to more better outcomes? For example, blocking the inflammation cascades, cytokine production, and things and whatnot. Some of the studies that have come out have sadly led to poorer outcomes. So I think the next step is figuring out when the timing of targeting this therapy. So if you want to sort of suppress the immune response, should we do it at the earlier phase, the middle phase, the later phase? So there's still lots to be figured out at that time. The other thing that sort of works hand in hand with this is the increasingly new discoveries of biomarkers. So in a procalcitonin is one that's sort of in mainstream use already, but there are other potential promising candidates coming up as well. So they can either guide in diagnosis, so whether or not we're dealing with sepsis, prognosis, so whether or not they'll lead to poorer outcomes or not, and monitoring and monitoring. So you can use that to see how well the patient is responding to therapy, and screening as well. So there are talks about using genetic polymorphisms to sort of guide personalized medicine. So some people might benefit more from certain therapies compared to other people. But these are things for the future that probably won't be seeing in the next few years or so. So that concludes the end of my talk. My slides are based on a paper on Nature that I've put a link here if anyone wants to read on in more detail. But yeah, I've tried to summarize them in about 20-25 minutes or so. Thank you.
Thank you so much, Ryan.
Thank you.
That was a lovely presentation, very concise to the point. And should we just start with any questions you guys have? No? Anybody online? Any questions? They can see. Any questions, guys? Okay, so let's just quickly sum this up. One quick point from the presentation, everybody. Let's go in circles. Starting with any one small point about sepsis.
I quite like this slide about how the points that we can take in mind when talking to relatives about the outcomes of patients in ICU and sepsis. I think that was quite useful.
Okay.
The changing definition of sepsis.
Yeah, that was very nice. Good. Okay.
Yeah.
virgin. Rita?
The use of procalcitonin, because we didn't normally used to do it before, but I've seen
But now, yeah.
now we're more.
More inclined to
Yeah.
it. Somebody on the back.
Regarding procalcitonin, I would say there are some quite good evidence for managing the antibiotic treatment with procalcitonin to stop antibiotic.
To stop antibiotics.
Yeah. It could allow a shorter duration of antibiotic that we aim in the.
So it can basically guide us as to when we need to
Yeah.
stop the antibiotics. It's like a guide. All right, perfect.
The C5a inhibition is quite interesting. I think that the current C5a inhibitor is probably the most expensive drug that we have on the market. It's like £100,000 per dose.
Which one?
Eculizumab, use it for a variety of TTP. That'd be interesting for sepsis. We'll be giving out one center in the transplant.
It's really complicated because all the drug that has been used to try to target the pathway between inflammation and coagulation, we had once the Xigris.
X-ray potency.
Yeah, and it was on the market for 5 years, maybe between 2002.
Sorry, I'm interrupting. Do you want to come in the front? I think the people that are online cannot see you.
Yeah. Actually, they did a second trial, and in the second trial, the drug was killing more people than saving. So it was withdrawn from the market in 2010, I think.
Yeah, it's part of the surviving sepsis.
Yeah.
Okay, Sophie.
Importance of de-escalating antibiotics in narrowing them down based on positive cultures.
Perfect. Peter.
Interesting about new treatment directions regarding suppressing the immune system.
But all right, sure. And I think the point that I was really interested in was what you talked about, the quality of life, how it affects the patients afterwards, and there's a lot more chance for them getting re-hospitalized after having sepsis.
I was a bit interested about is there any a sepsis bundle for the apart from the procalcitonin LDH along
Are you
with
talking about
the
sepsis 6 that we follow?
not the sepsis that for the investigation part routine tests for the patients who are septic.
Do you want to take on this?
What do you mean take on this? And what she
You want to answer? So you are asking about the sepsis bundle.
Yeah, is just the procalcitonin or is there anything else?
I think it really depends on the patient, from patient to patient, and about their condition, what sort of investigations we want to do for them. There's no hard and fast rule. I do think that the lactate is one of the guides, which is there in the bundles, all of the sepsis bundles, but there's no as such information other than that.
Yeah, well, guys said a lot, but the first thing that came to my mind was what Banu said about the worst outcomes. The general health decline that patients have after having sepsis and readmissions and that was the thing that I think was
I'm just quite surprised how many people seemingly end up with degree of PTSD.
Yeah.
Sepsis, 60% seems wild. I'm not saying it's wrong. I'm just very surprised. Never even give it a second thought.
Okay. If we don't have any questions, we will move on to Peter's presentation. Anybody online wants to comment? Have any questions? There are a lot of people. I can see 21 people.
I think Jacob mentioned whether asked if procalcitonin is useful for monitoring how septic the patient is. I don't believe so. I mean, there is a value that's reported on the labs, but I think it's we use a threshold. Below that, we don't really think it's sepsis, and above that, we think it is. But if anyone knows anything otherwise, please feel free. We don't use it as like in similar way that we use CRP, for example.
Not to my knowledge, anybody else can correct. Okay. So we're just gonna take a quick 5-minute break. Peter is gonna set up his presentation, and you guys can have the chocolates who are in the room, and the people who are online can just wait. Okay, Peter. Do we have the attendance? Everybody?
Anytime when you're mentioned free. It's like a calling time. Everybody needs you. For that?
All right. Otherwise,
Can I just do it? Or do we have to?
I spoke with the hematology, you know, E1. So I went to her on the 7th and the 8th because they were trying to change over from prototyping to warfarin. But the hematology don't think it's warfarin related.
Is this?
E1 with
E1.
INR.
But are you transferring to the morning bloods?
No, so we sent one at midday. It's fine, if not. She sent
Yeah,
two
you're gonna
Tuesday.
have to send it.
This one Tooba. This is how you try and get people to come.
The chocolate is it? I know. After a point, it just gets.
Oh, thank you.
I think this is, we've never had this many people attend before.
These hours are paid.
Yeah, 10.
These hours are paid.
Huh?
So these 2 hours are paid.
Is that?
I think that's what from the email it says.
Hours
are
are
paid, 2 hours.
It's
Is it 1 hour?
It says 2 hours.
Okay, guys, should we start with Peter's presentation?
Listen, she.
Get ready.
See, this is 7. I've got it in for 9. 9 people.
The Jordan just went out.
Oh, okay, fine.
I don't think I signed it.
Okay, let's stop.
I'm going to
You've not
say,
signed it.
I haven't signed. Thanks.
come on, yeah, we're wasting valuable.
That's it, yeah.
Sorry.
Come on.
Ready to go, right? My name's Peter, I'm one of the SHOs. Anyone online or here doesn't know. Brief presentation about undifferentiated shock. What is shock? That's a definition. What is it in practice for us? Hemodynamic instability and a signs of end organism. Simple. Some of the signs and symptoms that you'll see, common is to all or most shock, hypotension, tachycardia, tachypnea, oliguria, very important, cool extremities and mottling. Very specific sign is this mottling around the knee. Can be a endogenous catecholamine overdose causing this vasoconstriction in a desperate attempt to get through. It's a very bad sign. Altered mental status, dry mucous membranes, capillary refill time, peripheral pulses are weak. Patient may be bleeding. Can be broken down into 4 major classes: cardiogenic, obstructive, hypovolemic, and distributive. There are some of the examples there. Cardiogenic most commonly will be MI for us, or arrhythmias causing loss or lowering of cardiac output. Obstructive shocks, they're obstruction of the normal circulatory flow of the heart. Common causes that we'll see: pulmonary embolism, maybe cardiac tamponade, hopefully not tension pneumothorax. Abdominal compartment syndrome is one that we see seen relatively frequently, especially post-operatively pancreatitis patients. Hypovolemic, bleeding, fluid loss, various reasons, and distributive shock. Maybe an easier way to think of it is these 5 categories: arrhythmic, hypovolemic, left ventricular, right ventricular failure, and distributive shock. I don't have very much to say about that. Let's have a quick look. I'll send the slides out later. Right. So evaluation of shock. This should be after or during the initial resuscitation of the patient. You want to be looking for the clinical history, any cardiac history, any past medical history of an MI or a current MI, angios, chest pain, echoes, etc. Any history of VTE, signs of bleeding, if there's an acute abdomen there, signs of systemic infection, history of allergy and anaphylaxis, adrenal disease history, or any changes in medication. This is all things that you should be doing while the patient is being resuscitated or after the initial resuscitation. And the investigations that you want to send in probably everyone. Just do some bloods, point you towards what's going on with the blood gas. Is it metabolic? Is it respiratory? A full blood count and a metabolic panel, particularly important if you think the patient might be in some sort of crisis of their endocrine system, Addisonians, myxedemic with thyroid, whatever you like. Blood cultures if you suspect an infection, ECG, chest X-ray, and then these sort of emerging things that they're not exactly emerging anymore. Still really know how to do them, including myself. Echoes and fast scans will give you a good idea about what's going on. If they have a right ventricular dilatation, maybe it's something in the lungs. And then CT imaging based on what you think is going on. The CTPA, if it's something pulmonary, CT abdomen and pelvis if you suspect it's an acute abdomen, angiogram if there's bleeding, take things that you see. And this is the sort of bog standard initial management of everyone. Start with volume resuscitation, give fluid boluses of crystalloid and see what the response is. It can be a therapeutic and diagnostic test to give fluid to see if it gets better. If it's cardiogenic, it probably won't. If
it's hypovolemic or distributive or arithmetic, maybe it will. In the first instance, you don't want to be giving more than 1 or 2 litres of fluid, depending on what the patient presents with, unless it's a very obvious hypovolemic or hemorrhagic situation, in which case you want to replace light with light, blood, or crystalloid fluid if it's through dehydration, or if somebody's given a ton of diuretics for some reason. It does happen. And then if the fluid resuscitation doesn't work, then move on to thinking about vasopressors, or if it's not a pump failure, or ionotropes if it is a pump failure. And then obviously what happens next is based on initial response to treatment and then what you think is actually happening. So you're not going to give people tons of blood if you think they have cardiogenic shock. This is a little bit of a overview of what we can monitor at the bedside. So with a cardiac monitor, you can see if their pulse pressure is narrow, suggests a low cardiac output. If you've got a big pulse pressure, it could be a high output shock, which we'll move on to in a minute. There's the echocardiogram, the lung ultrasound, abdominal ultrasound, skin perfusion. These are all things that we probably should be learning how to do as we get further in our training. I think maybe at the moment it's something that mostly intensivists and anaesthetists learn how to do, probably, given how common ultrasound scans or scanning machines are, which have probably become a bit more common part of our curriculum. There's a lot of clinicians will come across patients who are shocked. This sort of thing is very useful. This is a sort of cheat sheet about what might be going on with the patient. Again, broken down into the general classifications of shock. How many more slides further?
Do you want to go back to the previous slide? This is a very busy slide. Just go through it, what it says.
It's a bit hard to see. So this has various types of shock categorized, maybe high output shock and low output shock. High output shock being things like septic shock, anaphylaxis, adrenal crisis, post-cardiac arrest, pancreatitis, neurogenic shock, and if the patient's been given vasodilatory medications. So the issue isn't with the heart itself, the heart's pumping things out fine, but the problem is in the periphery, either with poor systemic vascular resistance, low systemic vascular resistance, or leaky capillaries, or a mixture of actually both in septic shock, as Ryan was telling us, a bit of pump failure, a bit of distributive leaky failure. And then, yeah, as it goes on, hypovolemic shock, the signs you might see, right ventricular failure. I mean, read it. There's nothing much on there to say.
You want to summarize everything, Peter, into 4 points?
It's 4 points.
For everybody, with the big box. Yeah.
Resuscitation is the most important thing to begin with.
Resuscitation is the most important, guys. Please, thanks.
So start with that if you don't know what's going on. Start your investigations wide. Narrow them down when you know what's going on. Bedside ultrasound is a useful tool. Ask for senior advice.
Okay. Yeah, I think for shock, again, the thing is to identify early and to consider what the shock cause is, and then to narrow it down and take it from there. Anybody has got any questions about shock when it's undifferentiated and sort of how to differentiate it into what type is? Anybody online? Okay. We each go around and do one quick point about shock. Anything that you want to talk about, but should be related to shock.
You should ask the people.
You first.
Yeah, sorry, yeah.
It was a nice summary of the classifications. It was a good summary of the classifications, like.
Classification as in the types of shock.
Yeah, so like the different types of classifications, also for example, high output, low output. Yeah, it's just, I don't know.
Okay.
There was a slide about the investigations where focus, echo, everything was given along with palpating the peripheries, which again it's brings it down to clinical evaluation.
And the bedside investigation, ultrasound, lung, yeah, all right, sure. That was a nice one. Rita, any comments? Any
Early resuscitation.
early resuscitation? Sophia.
For me, in experience, you should be trained how to do just bedside ultrasound. This for PE, especially time.
For PE,
You need to assess bedside.
sure.
It's a very big tool.
The knee modelling.
Sorry?
The knee modelling is quite a good sign. I've actually not seen it before here, but I've heard about it being used. Not seeing it because probably I don't look.
Anything about shock?
I agree with Barn, but the classification was quite like, most of the times it's the output, like cardiac output, like
Yeah.
reduced. I agree with that. And early resuscitation, as I mentioned, is the most
Sure.
important.
So if you see a patient, are you able to, examine and do all of the bedside things that is mentioned, and then say that this is definitely cardiogenic shock, hypovolemic shock, looking at the patient?
As you mentioned initially, we broadened up the investigation in the beginning.
Yeah.
Once we, like after giving for example, fluid resuscitation, if the blood pressure and started improving, we can narrow it down to like some kind of like a low output shock so that we can focus towards the specific directions.
Specific type
Yeah.
of shock. And there is always a sort of overlap always. There can be both two types of shock can coexist in one patient as well. So sometimes the clinical picture can be confusing in that sense as well. It's always not one single type of shock in a patient. It can be a mixed as well.
Yeah, I thought it was interesting what Peter mentioned about, I think the point of care ultrasound should be taught to more specialists,
Yeah.
so more people can have access to do it because it narrows the investigation and we direct after we do our initial clinical assessment.
Sure.
I wasn't there for long.
But you do know about shock.
I do know about
Anything,
shock,
anything
yes.
about shock.
What's this knee modelling thing? That's interesting. Like,
It's quite a sensitive sign of like bad.
Bring this
Do you want to repeat it, Peter?
You're right.
I think the modelling is worse than prognosis.
what specifically knee?
I think I've mostly seen it on the patients in the peripheries, like towards the foot, and it slowly comes up. It's not always on the knee area localized.
No, but I think it's relatively somehow been well validated that the size of the mottling around the knee, particularly for or a particularly.
Do you have a good evidence paper that you want to share with us about this knee model?
Off the top of my head, no,
Okay,
but I'll find it.
sure.
Comment idea.
All right. Sure. Thank you so much, Peter. That was a nice presentation. Any questions, guys? Any other comments? Online people? You wanna? Should we just quickly? Wanna come? There. Mustafa Karim. Mustafa.
Destroys.
Hi.
Yes,
Hi. Hi, Mustafa, do you want to quickly say anything about Peter's presentation, talk, anything?
I did like Ryan's speech, to be honest. It reminded me mostly about the pathophysiology.
Guys, please. Literally 2-3 minutes. Sorry, can you repeat that?
There's nothing like shown on the presentation.
Okay.
It's a white page.
I quite don't understand what he's saying. Anybody can repeat this for us?
He likes Ryan's presentation.
He likes Ryan's presentation. What about Peter's presentation? We're talking about chalk here, guys, please.
If it was poorly put together, you could say so.
Yes.
I don't mind.
Okay, thank you, Mustafa, for your input. Okay, guys that are online, please put your names in the chat box so that we can mark your attendance. And next week, the presentation is one of the ITU consultants, Dr. Edgar, and it's going to be on renal replacement therapy. So we'll see you next time. Same place. Thank you so much.
Thank you.
And please, can you fill up the feedback form? I'm going to put up the QR code. Everybody, please. We didn't get it. And the people that are online, can they see this QR code? Please fill up the feedback form.
All right. The one. Yeah.
Thank you, guys. All of these classes are being recorded. So, yeah, thank you.
Yeah, so just stop the journal for now.